how do you create opportunity in a crisis? Well, after Beata's talk, I think we can all certainly agree that we are living in highly volatile times, facing global health pandemics, climate change, wars, and much more, all of which requires us to rethink our traditional business models and act with courage. 2.5 years ago, the COVID-19 pandemic plunged us all into a global health crisis and economic downturn. And at such times, it's easy to just focus on the immediate question of how do we cope with this crisis now. But the truth is that every crisis, no matter how deeply unsettling and stressful it is, also contains potential for opportunity. In the spring of 2020, my organization, Gavi, the Vaccine Alliance, a nonprofit organization with just about 300 employees, was entrusted with quite a daunting task of leading on the procurement and delivery of vaccines workstream of a program that was set up by WHO. And the specific billion-dollar question that we were tasked with answering was, how do we ensure that once COVID-19 vaccines become available, they are distributed in an equitable manner so as to avoid a situation where they're available only to a handful of rich countries that managed to secure bilateral deals with manufacturers. Now, you may recall that in the summer of 2020, this was the time when the shape and timeline of the pandemic were completely unknown. The symptoms and impact of the virus were still not well understood, and no one yet knew if or which vaccine would work. But we didn't have the luxury of time to wait for those questions to be answered before creating and market testing an equity solution. Now, it's needless to say, it's very difficult, if not impossible, to build a car while you're driving it. So we had to try and test as we went along, adding things, removing things. We had to navigate the same dynamic landscape as national leaders, responding to changes in disease patterns, infection rates, vaccine trial results, and manufacturing supply. And we had to do all of this while keeping the world's leaders engaged and maintaining a vision and strategy that would hold both rich and poor countries and everyone in between. So how did we do this? We created the COVAX facility, whose purpose was to be a global program for the development, production, and distribution of COVID vaccines. We were guided by three basic objectives of the facility. First, we wanted to incentivize manufacturers to expand vaccine production capacity while they were still developing their vaccines. And what do I mean by this? Well, as you may know, manufacturers are reluctant to risk making significant investments that are needed to scale up vaccine manufacturing facilities until they have received approval for their vaccine. But if we had waited for that, that would have led to significant delays and even greater shortages of vaccines than what we ended up seeing in the end. And so to avoid this, Gavi, on behalf of the COVAX facility, ended up entering into so-called advanced purchase commitment agreements with vaccine manufacturers, where we were essentially telling manufacturers, please go ahead and scale up your production because we are guaranteeing you the demand of X number of doses. Another goal of the facility was, as I said, to guarantee fair and equitable access to COVID vaccines for every country in the world in order to avoid the situations where vaccines were available only to a handful of high-income countries that were privileged to enter into bilateral deals with manufacturers. And the final goal of the COVAX facility was to develop the largest and most diverse, actively managed portfolio of COVID vaccine candidates in order to maximize the probability of success so that the best vaccines would ultimately be made available. So how did it work? And I'm going to get a bit technical here, but I'm a lawyer, I'm into details, and I'm sure you want to know the nitty-gritty of the business deal of this product. So we had high-income countries and upper-middle-income countries that are so-called self-financing participants, and they were required to pay for their doses. And then you have a group of 92 low-income and lower-middle-income countries that participated in the facility on a funded basis. So they were supported by donors who were basically paying for their vaccines. And then Gavi's role was to administer the facility, and as I said, to enter into arrangements with numerous manufacturers to secure access to vaccine supply on the basis that only appropriately approved vaccines would ultimately be procured through the facility. And what do I mean by appropriately approved? In order to be included in the COVAX portfolio, the vaccine had to be either pre-qualified by WHO or licensed by one of the so-called stringent regulatory authorities. I often get the question as to why we wanted rich countries in the mix. So the reason we wanted to have those wealthy self-financing countries in the mix is because COVAX was set up in the summer of 2020 at a time when there was no available vaccine and no one knew when it would become available. What we did know, however, is that once the vaccine became available, rich countries would be competing for it with the poor countries. So the thinking was that it would be good for those high-income countries to have some skin in the game in the program. Now, what was in it for them? So the reason this was attractive for them in the first place is that while they were striking bilateral deals with manufacturers, the idea was that no one knew which vaccine candidates would ultimately be successful. So the USP of COVAX for them was that it would offer them access to a larger pool of vaccine candidates than any country could access on its own. And as you will see in the next couple of slides, structuring a deal that works for both self-financing countries and at the same time doesn't expose us as an organization to huge risks was by far the most challenging aspect of this facility. Now, our initial thinking was that self-financing participants would be required to commit to enter into legally binding commitments to purchase through the facility enough doses to vaccinate 20% of their population. And they were required to pay us the so-called commitment amount. The commitment amount was calculated based on the weighted average estimated cost per dose multiplied by the total participant doses. Total participant doses was the number equal to 20% of the country's population, and this number, weighted average estimated cost per dose, was extremely tricky. It ended up being $10.55. But where does this figure come from? Well, this was calculated based on the latest available pricing information from manufacturers in the portfolio that we had under our consideration, and then we took the estimated weighted average price across the portfolio. And as you can imagine, this was by far the most challenging part of designing this deal because we were asking countries to pay in September of 2020, but we didn't have the actual price at the time. So importantly, of course, participants would actually end up paying the actual price once the approved vaccine became available, which meant that if it turned out that this estimated cost per dose was higher than the actual price, you would get more doses for your commitment amount. If it was lower than the actual price, then you would get fewer doses. Now, importantly, in this model, because we were asking countries to commit to purchase vaccines, and off the back of those commitments, Gavi as an intermediary was entering into binding commitments with manufacturers, the idea was that once doses became available, and they met the approved criteria, countries would have to purchase them. Otherwise, we would be exposing our organization to huge risks where we would be committed to pay to manufacturers, having guaranteed certain number of doses to them, and countries could simply turn around and say we've changed our mind. However, unsurprisingly, many rich countries, which also happen to be our donors, didn't like this proposal because they didn't like the idea of not having a choice of which vaccines they had to buy. So we ended up with two models in order to accommodate everyone. We ended up with a committed purchase model, which is essentially what we were initially proposing for everyone, where participants make a small down payment subject to being allocated doses of approved vaccine, then they have to procure those doses. And the only opt-out that they had in this model was if the actual price ended up being more than $21.10, which is twice the estimated weighted average cost per dose of $10.55. And then we had a second model as well, which is the optional purchase arrangement, where participants were able to decide whether to purchase any approved vaccine candidate allocated to them. As a result, they had a slightly higher down payment, and we gave them 2 windows during which they could decide on a particular vaccine candidate. The first window was before Gavi enters into an agreement with manufacturer, and the second window is later in the clinical development process before Gavi confirms orders with manufacturers. So that's in a nutshell how the structure worked. So what happened next? Well, building a car while you're driving it entails a number of risks that you simply have to take on, and we were no exception. As you can see, one of the biggest risks was country default risk. So self-financing participants not paying on time or not paying at all, while Gavi still having to comply with its commitment to pay for the doses to manufacturers. And we've really thought about a lot of possible mitigants, even structuring it through a special purpose vehicle, SPV. We then decided that countries that had a credit rating of B or below would be asked to obtain a guarantee, ideally from a commercial bank or multilateral development bank. But that turned out to be difficult and problematic for a number of countries. And so we ended up, again, being quite accommodating and even accepting a guarantee from the country's Ministry of Finance, which is something, given that the commitment agreement was typically signed by the Ministry of Health, which doesn't hold the strings of the purse, but still having a guarantee from the Ministry of Finance exposes you to the same sovereign default risk as the commitment agreement itself. So then, with the assistance of Citibank, which was our financial advisor, we ended up getting default insurance from a commercial insurer, and we had to pay for it, of course. Another risk stemmed from the fact that Gavi was acting, as you can see, as an intermediary. We were not the ones supplying the doses. So ultimately, countries were required to enter into supply agreements, either directly with manufacturers or with a procurement agent, which was UNICEF in most cases. So what happened if they failed to do so, if they didn't agree on the supply terms? Well, this could obviously result in doses not being ultimately delivered to countries and Gavi still having to pay the firmly committed doses to manufacturers. A difficult one to solve, but what we tried to do is agree on key terms and conditions of supply contracts in our advanced purchase agreements with manufacturers so that at least there were no surprises for the countries as to what manufacturers were asking for. Another big challenge was that back in the summer of 2020, we were negotiating very much in the supplier market. We were unable to get firm supply schedules from manufacturers, which, as you know, is a key term in any supply contract. By when are you going to deliver? But manufacturers themselves didn't know when and whether they were going to have a successful vaccine product, so they couldn't commit to delivering it to COVAX by a particular date. In addition, many manufacturers had tiered pricing, so they were charging rich countries more for a vaccine dose than poor countries, which makes sense. But then that also meant that once vaccine did become available, many manufacturers ended up taking a commercial decision to prioritize wealthy countries in their supply schedules because they were paying a higher price. And that, of course, has been extremely challenging. What we've tried to do is we've obviously tried to put pressure on manufacturers to be more transparent with their order timelines. We try to make them understand that by making those business decisions and prioritize supply to rich countries over COVAX, they were not prioritizing supply to the majority of the world's population, which again, in the long run, impacts virus transmission in the world and ironically impacts wealthy countries' economies. We also introduced something called slot swapping. So if the high-income countries were ahead of COVAX in the supply queue, didn't need those doses, we tried to convince them to swap their slot with us, to step back and let COVAX take their place in the queue. And finally, we introduced a dose donation program, whereby wealthy countries could donate their excess doses to COVAX. That, too, has not been easy because we've struggled to have those donations be predictable and be arranged for those vaccines that have long enough of a shelf life so that we can organize transportation and delivery to countries once a high-income country has decided to donate its excess doses. The final challenge to which we never found a solution, and I think anyone has, is variants. And whether vaccines will prove efficacious against new variants. The problem is that vaccines have a very long lead time for delivery. So once you say, yes, I want those vaccines, you have several months of lead time. And I think we can all see that there is a real risk that in the interim it turns out that that vaccine is no longer efficacious against a new strain. Ultimately, the biggest challenge with this project is that we have been putting together something that's never been done before, so in many ways it is precedent-setting. But despite all the challenges, we ended up delivering nearly 2 billion doses to about 150 countries. So I'm going to conclude with some lessons learned and what could be done to anticipate crises in the future and prepare for them. So the biggest hindrance, as you saw, to the successful rollout of this global vaccine program has been vaccine nationalism and hoarding of vaccines by high-income countries. Of course, we can all agree that this is not helpful because in the long run, it hurts global economy. But I do think that future iterations of COVAX and similar programs will just simply have to take into account national interests in the design phase from the beginning. We simply need to assume that government leaders will prioritize their own populations and work with that, and perhaps get vaccine manufacturers to commit that they will allocate certain percentage of supply to COVAX by a certain date. Another issue was that we didn't have money up front, so we had to spend a lot of time fundraising. What we're doing now is looking at ways in which money could be put into a central fund that could potentially be available as a global pandemic funding mechanism, but in a way that ensures that we're not just adding another layer of bureaucracy that slows things down once swift response is needed. We clearly need to have funding immediately available for the next pandemic. So we are looking at the most efficient ways to achieve this through so-called contingent pledges by governments to global agencies like Gavi that are only triggered if a disaster strikes and thereby enable those agencies to respond quickly. And another area that we're looking at is increasing manufacturing capacity. Clearly, during a pandemic, you need several times more doses of a vaccine that are normally produced. And manufacturing facilities are predominantly concentrated in developed countries, which has played into this vaccine hoarding through export bans and has hindered equitable access. So clearly there is need to increase global manufacturing capacity and achieve greater geographical diversity, which sounds great in theory, but the reality is that vaccine manufacturing facilities cost more than $500 million to build, and it's not a viable business model if there's a chance that they would sit idle in between crises. So we are looking at the transfer of technologies to build facilities that are geared towards increasing the supply of non-pandemic vaccines, in other words, those vaccines that are used in routine immunization programs, but in a way that those facilities could quickly be scaled up and pivoted towards the production of pandemic vaccines when needed. So there, ladies and gentlemen, that's how we ended up creating the global COVID vaccine distribution program with lots of uncertainty and unknowns, but doing the best in circumstances. And I really hope that innovations and learnings from COVAX will be looked at for future similar initiatives. Thank you.